Good morning and welcome to our monthly webcast. This is session number 115. I am your moderator Samir Mehta. A very happy new year to all of you who are listening to our webcast. All I can assure you is in 2019 we will continue to consistently bring you outstanding and teaching cases from the Cardiac Catheterization Laboratory at Mount Sinai, always remaining academic and never without any conflict of interest. We start 2019 with the complex unprotected left main case, where I hope we'll be able to show you our approach to this case. You will also learn how do you differentiate and plan for a single stent approach versus a elective two-stent strategy. You will learn how to prepare a lesion, and of course we will demonstrate the use of IVUS and discuss the need for any hemodynamic protection. With this introduction and once again welcoming you to 2019 with our webcast, let me take you to the Cardiac Catheterization Laboratory.
All right.
Sameen, good morning. Anu, good morning.
Good morning.
A very happy new year to you and your staff.
And of course, to our CCC Live webcast viewers, which has grown over 10,000 per episode per month and 138 countries. So clearly, good morning to all and Happy New Year from Mount Sinai Cath Lab. And as you pointed out, we always have taught in the distal left main double stent strategy. But this time we are going to show in a case with a distal left main bifurcation, which by definition is Medina 111, that how can you come out with one stent, and of course there is always a chance that you may have to use a bailout second stent approach, but a goal focused will be, and I'll give the reason that why we want to come out with a one stent approach in this particular case compared to our routine two stent approach, which is the DK crush or mini crush. We favor mini crush because of less steps and yet very good outcomes and results short and long term in our hands.
Plus the biggest challenge, elderly gentlemen.
That's true. And patient is on oral anticoagulation, NOAC, because of the recurrent DVT. So elderly, frailty, poor coordination, lot of could fall, and those cases are clearly more predisposed to some fall and requiring interruption of DAPT. And we know that if you are double stent and you interrupt the DAPT, you are in more trouble. So that's the biggest challenge which we'll have in this particular case.
So the decision for PCI here was relatively straightforward.
That's because of the lesion and the symptoms and I'll take you through, and let's start with our slide. First we show the volume. As over the years that has been a practice in America and show also here, not outside, that we continue to have a little decline in intervention over the years. You can see first time we aggregate intervention increased by 1.1% in Mount Sinai Cath Lab. So plus point. And this is largely because of complex cases referred to us. So we actually have the case mix index and acuity much higher of our PCI patients, and you see the numbers. PTA remained flat, structural remained flat, and we did various other new structural interventions, including tricuspid clip and tricuspid valve replacement, and the PCI number went up by 2%. More important, which is what we always took the pride in, is the complication. So this is the last 5 year temporal trends in complications of PCI at Mount Sinai, and you can see the in-hospital death. 11 of the 3415 patient did not go home with the urgent CABG, of one patient with 0.002, and overall less than 1% overall complication. So just to say, we continue to dominate the New York and perhaps the entire United States in terms of the volume and the safety of PCI, and 2018 was not new in that regard.
Sameen, congratulations. I am impressed always. You mention just a minimal increase. Compare that with what is happening around the country. The numbers are consistently going down. But to be doing so many complex interventions, which I think may even be the majority of your cases with such low complications. That is exactly what we are trying to demonstrate in our webcast.
Fantastic. So with that note, we continue our supporters, the disclosures, no change. And this is a 86-year-old female who actually had stable angina for many years and has a documented ischemia a few years ago, but did not want to go for cath, but put on a maximum medical therapy. Now because of a little more symptoms, the patient underwent cardiac catheterization at outside hospital, which revealed left main and two vessel disease, which will show you calcific, and there is a focal aneurysm of the LAD, and patient was recommended CABG. So Anu, you want to just take us through?
So this is the LV function. EDP was normal EF, and right coronary artery essentially normal. Some moderate disease in the mid RCA, mid PDA, anterior takeoff. We needed AR2 to engage it. But this is where we are with the left main. Definitely calcific distal left main, and we took several pictures to exactly see the ostium of the circ. But what you see is that aneurysm probably coming from the left main itself. You see there? Here was not clear, but in the cranial view, it's probably coming from the left main, and then you have the mid LAD, another 80-90% disease. But
it's a very
every view,
I
think the circ is okay.
Yeah, actually, maybe what happened is this, the angiogram which we put in the webcast, the e-blast, was on May. So almost 7 months ago, May 14, 2018, and patient still continue, CABG was recommended, but did not go for it, and of course came for consultation to Anu and decided for, agreed for PCI. But key is that this aneurysm has become bigger, and it seems to be, it was clearly, we have the old angiogram from May, it was in the LAD. So I think it's just the appearance of the aneurysm. It is definitely coming from the LAD, because it was coming from the LAD few months ago. And it just has become bigger.
You think there is filling defect thrombus in the aneurysm?
Well, I mean, that always happens, a little bit of thrombus right there on the top.
Yeah. How does that change your strategy, Sameer?
No, we knew about it. That idea would be that we put a stent across and aneurysm will falls down. We actually have a publication. We had a giant aneurysm, 12 millimeter in size. This probably will be every 12. Actually, we have, that one was 22 millimeter of the right coronary, which we put a stent, and that aneurysm closed, and we showed the, have a follow-up CTA, and that paper was published by one of my fellow in Cath, in cardiovascular intervention. So here what will happen is we have to see what's happening with the ostial circ. Once you put a stent across from the left main to LAD, aneurysm will become 1/3 the size. What happened? Because there is no flow, it just falls on it.
Right. Anu, the lesion in the proximal to the mid LAD also looks to be severe?
Yeah.
Yes.
That always was, yes.
Not calcified, but significant disease. Yeah. So what I would suggest that we would go with 175 burr, just take care of the left main with 175 burr, and
provisional crossover
stent across.
Yeah.
Sounds a plan.
So, and the question will be that if there is a ostial circumflex involved, there is a disease, we do the IVUS. You want to plan was to do the IVUS, and I think we definitely should do IVUS in this case. Will be very interesting for people to see. And then is there an ostial circ involved? If it is, then maybe just do a cutting balloon and put a stent across, and if everything looks good, do nothing. Otherwise, do a final kissing balloon inflation. So that is the plan.
Let's take care of two matters right here. Number one, you absolutely, for most or almost every left main, you will do a lesion preparation further.
That's correct.
And
the second part is IVUS should be considered mandatory?
Well,
I would say, I mean, though we don't routinely do it, but the recommendations are pre and post, IVUS of the post definitely for stent optimization of left main. Documents well stent expansion.
You are probably going to be using a rotational ablation here?
Yes.
What about, I know the EF you showed looked 40 to 45%, maybe even normal. No need for any hemodynamic support?
No.
Yeah, we expect at this time that no, but I know if somebody wants to use hemodynamic support, and this is exactly type of patient which FDA got FDA approved Impala, those who are high risk, even high coronary anatomy, high risk coronary anatomy which this patient has, and chances because they may develop acute decompensation during procedure even for short time when we occlude the left main and putting an Impala. So Impala is approved for this purpose at this time. It's a complex heart team discussion already took place, has suggested patient should have a PCI. So clearly you have that criteria, the basic criteria of indication for Impala, despite the near normal LV function. So just while we are getting ready for the IVUS, we just go through the remaining slide.
No, I just want to go back to that angiogram of the femoral. Yeah, there's no femoral head. I know it's not, but how is this person walking?
Yeah. So that's why patient has a very poor coordination. Okay, let's go to the slides quickly while we are getting the IVUS ready in few minutes.
No, so we'll IVUS into LAD. You want see wire will go into circ and IVUS, because if you need to document circ disease or no disease, we have to IVUS into the circ also.
We'll see, or you can see the osteum, you may not.
No.
But these are the risk factors, and the basically when patient was seen just about 2 weeks ago, was started on aspirin, otherwise was taking metoprolol, torvastatin, apixaban, isosorbide and ranolazine, and aspirin was just recently added in the to the regime. Overall syntax score is 30. Again we have to see that Medina was 111, and today is complex intervention of the calcific left main, bifurcation using rotational atherectomy, and planned one-stent crossover technique with IVUS guidance. One-stent technique because the fall risk, potential depth interruption. So single stent is the one we want to do in this particular case. Not necessarily just because patient is on NOAC. Yeah. And NOACs also you try to avoid.
Risk of bleed is very high with this age. If you have a triple antiplatelet therapy, you want to stay on one antiplatelet therapy in her.
That is correct. So then what is required is that these patients have a heart team discussion, and STS risk and syntax score we already calculated 30, and STS is 1.2. So overall patient has a low risk of the surgery, but basically of the poor general medical condition. Is it patient appropriate for PCI? So this patient is in the red category for the PCI cat, but after it become appropriate when you have a heart team discussion as by the guideline, the CTS will decline due to old age and frailty. So this case is appropriate in my opinion to go for PCI, and so while we are getting ready for the IVUS, let's just quickly go through the 2 points. And that 2 points, basically we always talk about FFR during PCI, but we are talking about now FFR during angio in the CABG. So data of FFR guided versus angio guided CABG, and the second is the temporal trains of OC categories in PCI. So PCI always under scrutiny, and we want to be ahead of it. So any new topic comes in, we try to show it. So first one is the FFR guided. So clearly we know that CABG is superior to PCI in many aspects, particularly patients with a multivessel disease or diabetics. Those are the meta-analysis which we presented just in our last webcast. So then FFR also have shown, based on the FFR guided PCI, having a better outcome if it is less than 0.8 versus medical therapy, and the outcome is similar to registry, that means FFR of more than 0.8. So clearly these are the two facts which we know, and also we know this is a FAME 2. FAME 1, that FFR guided PCI reduce MI, TVR, cost, stent use, dye use, and overall MACE. So FFR is beneficial in multivessel disease patients. So therefore that makes the guideline that the presence of an asymptomatic or symptomatic intermediate coronary disease, in my opinion, unless it's a subtotal or MI, FFR guided PCI should be routine. As you know, in our cath lab, we actually have made 60% as the threshold for PCI, FFR guided PCI to be done. So now, what about the FFR and CABG evidence? What do we know? We know that CABG data are based on angiographic interpretation, which led to lower repeat revascularization, durable angina relief, lower mortality in subgroups, and better quality of life parameters. So these data, the benefit of CABG which we see so far have been based on the angiography only.
Okay, somebody.
Yeah. So now the question then comes is that FFR guidance, you could say maybe that if you use FFR, you will have a lower graft occlusion,
Yeah.
lower number of grafts with lower anesthesia time and pump time, and maybe lower follow-up MACE of MI and death. So makes sense. And the question then comes is, sorry, what happened here? Yeah. So what about the role of CABG in protection from adverse impact of proximal lesion progression, which leads to different decreased mortality? Because there is a hypothesis that why there is a difference in mortality in PCI versus CABG is kind of suggested that maybe by putting a graft into the mid vessel, the bad effect or adverse effect of the proximal vessel occlusion is basically avoided. So therefore proximal may close, but because of distal vessel filled by the graft, that protection goes away if you just go with the FFR and you have some progression of the disease proximally. And we think that that was one of the factor of decreased mortality. So therefore, the bypass surgery and FFR, there is an editorial couple of years ago in the NEJM that usefulness of the FFR in selecting patients with multi-vessel CAD or CABG or in identifying bypass graft targets in patients undergoing CABG has not been studied. So patient, because it's a very complex issue. So therefore, this field is evolving with the data. That first data came from Belgium group, Dr. Barbato and Dr. Tau have published extensively. They took their own data, retrospective analysis of their patients, about 600 plus, and patients which had FFR, even in one vessel, which was the ambiguous, the intermediate vessel stenosis, the FFR guided compared with the angio guided. So 429 patients were compared against 198. And you can see here that in FFR guided of the 198, the patients 186, 171 finally got the CABG. So other were excluded because FFR was more than 0.8 in those cases and did not have a bypass surgery. So very, very important. And then of course a patient with the angio guided, whatever the lesion more than 50% was associated, they went ahead and put the bypass on those patients. So then what was seen is basically, as you can see here, that overall number of anastomosis, the pump time, duration time, the anesthesia time was all lower in the FFR guided group compared to angiographic guided group. So clearly the FFR what did, it helped to decrease the overall anesthesia time, and number of grafts were done less because of obviously that many of the anatomical lesions which looks 70% FFR or more than 0.8 and did not get the bypass. So what did they find? That overall MACE-free survival at 36 months. And you can see here that they're clearly in favor of the FFR guided group. And these are the individual endpoints, the death, the TVR. So both were lower in the angio guided group versus FFR guided group. Again, I want to say it's not a randomized trial. This is from their own database, and FFR guided was the case. Even if they did a one vessel FFR was put into the FFR guided group, and they concluded that FFR guided CABG was associated with a lower number of graft anastomosis and a lower rate of on pump surgery compared with angiography guided coronary artery bypass surgery, and they did not result in a higher event rate at 36 month follow up. So these data, then they presented the data at 6 years follow up, same group, and showing basically the similar message that all events were statistically or numerically lower in the FFR guided group compared to the angiographic guided group, with the death and MI at 6 years significantly lower in the FFR guided group. So it makes sense, and these are the individual endpoints including the TVR and so. So clearly the whole issue was whether you use a 1 graft, 2 grafts or 3 grafts, the benefit is still remain of the FFR guided subsequent revascularization. So seems to be in a non-randomized data was very good. Everybody excited that looks like FFR should be the way to go. And there are a lot of the questions that if you have a stenosis, whether less severe stenosis or more severe stenosis, angiographic, they have a higher graft occlusion. We know the comparative flow which we see so many times in patients. So once you have comparative flow, many times the graft occlusion occurs more because the proximal lesion where the graft is inserted is not significant, and the graft is kind of useless because you have more native flow. So then the first randomized trial, the fractional flow reserve versus angiographically guided coronary artery bypass grafting, which is called FARGO trial, was basically presented. A small number of patients, but the patients were randomized. Was first patient had a cardiac catheterization and patient had FFR already. Then those who needed CABG were decided based on the angiography, the angiography group, and the second group was the FFR guided. So basically it was told that these lesions are the one should get bypassed. So clearly the change in strategy took place after the initial presentation of initial heart team discussion. So basically FFR guided versus angiographic guided. So they actually followed those patients, and the endpoint was 6-month angiogram and the graft failure and FFR of the deferred lesion. So patients in the FFR group, those who have more than 0.8 but angiographically were significant, and then they did not get the bypass surgery, they did the FFR, brought the patients back. So what were the results? This was the first randomized trial, and they basically showed, as you can see here, the arterial graft numbers, and so similar what we knew earlier, the anesthesia time, and so all were lower in the FFR guided group compared to the overall the angiographic guided group. So clearly your clamp time, your duration, all hospitalization was not different, and whether you get arterial or venous bypass was not different also. So basically then the 6 months primary endpoint was the graft failure. As you can see that overall graft failure was equal in two groups, 28 versus 33%, and you can see the 16 graft failed in the FFR group and 12 graft failed in the angio group. So these were about 50 patients, and MACE, death, MI, stroke or MACI was no different between two groups. So clearly showed at 6 months FFR guided versus angiography guided was no different. So clearly kind of a contradictory results than our Denmark group that which earlier showed that FFR non-randomized way was beneficial compared to the angiography guided. So these are the individual further endpoints, and clearly showed that if the patient they followed the patient, and they said that if the deferred lesion which was more than 0.8, if became less than 0.8 is equivalent to kind of graft failure. If you take that into equation, of course at follow up you had a higher event rate, but more importantly is here, and that is that patients that the change in the FFR before CABG and after 6 months in the deferred. So many of these patients, as you can see, 37.5% of patients, we are going to come back in quickly, 37.5% of patients who had FFR of more than 0.8 at follow up had a FFR of less than 0.8. So that was a really alarming, the change in FFR of the deferred lesion, and really so they basically concluded that FFR did not have any angiographic compared to angio in terms of the clinical outcome, but FFR was reduced significantly after 6 months in the deferred lesion. So big concern, because we know once you are less than 0.8, these patients are going to have an event at follow up. So big trouble, and the nice editorial say that FFR is just a part of the whole equation. And there is one major randomized trial which was the same group which you earlier presented, the graffiti. And we will answer this. This trial is a large number of patients. We will answer that question, FFR guided or angiographic guided, with a 12-month follow-up, that what will be the outcome with the graft patency and MACE. So with that note, Anu, we go back to the angiogram now.
Yeah, we
did the IVUS
trouble in wiring the LED, but we went to the LAO view, you can see here.
Okay.
So essentially it is coming from the distal left main, the aneurysm.
Anu,
Okay,
the
you're coming
problem
from
in the wire, was it it's coiling in the aneurysm?
Yeah, coiling in the aneurysm. That's why I went to this view. You see that?
Yeah.
So it is coming off the probably
circ looks all right, no?
yes, looked all right. So that's why the wire went easy now when I came to this view into the circ.
Right.
This is how you see that the wire went okay.
Yep.
So I needed fine cross, or you need a balloon support so that you
So
are
why
able
are
to
you-
navigate through the
You're wiring the
Wow.
circ to IVUS?
yeah. So I thought let me do the IVUS.
Okay.
But IVUS catheter is not making a turn. It
Right.
could be because significant disease of the left main,
the
calcium,
tortuosity
or the
at the-
aneurysm.
Right.
So the IVUS, you show the IVUS. No, not that. Hello, just the distal left main. We recorded.
Okay, let's flush, do
Yeah,
it again.
we see it now.
Yeah. We're going to do it quick, flush and go again.
Why is she doing that?
Okay, let's flush a little better. You have to pull back. No, pull back first. A little flush. Okay, now go in. Now, why it should not be going? That's another. That means.
No, it's just I think the way
Huh?
the vessel is taking off.
Or
You can
the
see
very
that, right?
critical left main.
Yeah.
Huh?
So very critical left main. Yeah.
I think it's very eccentric and maybe not a good idea to push it.
Yeah. That's all. You saw that, right? I
So,
mean,
yeah.
left main did not look. I don't know at the level of the left main, it did not look critical, but it's not going.
You
So
mean
now I think we take the wire out. Either way, we cannot do anything to the circ.
Right.
Okay. Understood. Yeah. Right now, no. But question is, do you need a supercross to make a turn for the LED?
No, what I'll try again, same fine cross, and we'll go with a miracle with an acute angle and see. If not, then you have to use a supercross.
Samin, very nice cover of an
Don't
excellent
destroy the
topic, very relevant about the role of FFR in CABG.
You know, these guys
It's contaminated now. You're touching it everywhere. Huh? Covered what? This is a touch. Remove this. You have to change it new. Yes. No,
Right.
actually, this was a totally different field. Nobody talks about this FFR. Take that away. We have to do a new
Well,
one.
first of all,
No, take
as
this away
on a
and change the
personal
glove.
note, the Fargo trial, Dr. Leif Thuysen is a very dear friend from Denmark who worked with Dr. Anderson on the
Go to the
Danami
same
1
view.
and 2 trials.
Yes.
Remarkable physicians, and their data, I think, balances the perspective, although the numbers are relatively
What is
small,
happening
but
with the-
hopefully the graffiti trial
What's happening
will
with the table?
show us more information. Samin, there is a most interesting question which has just come through.
That will use later. Yeah. Yes.
And you just mentioned in the introduction the webcast being seen 10,000 viewers in 138 countries. I think it suddenly has become 139 today.
Oh.
I have just received a question, a remarkable observation from Dr. Muhammad Altir, who I have welcomed. He's from Libya.
All right.
I don't think we've had
Yeah.
a physician from Libya before.
Yes.
We may have missed it. Sometimes they don't list the country. And Dr. Altir mentions that he recently did a patient with the STEMI for the RCA who had aneurysm in the proximal LAD, for which he was recommending surgery, and for the comorbidities the patient did not go for surgery. So he's looking forward to your case and how the aneurysm behaves after stenting.
Right.
Dr. Altir, welcome to the webcast, and hopefully this will be an educational case for you, not only for the unprotected left main PCI, but specifically to your observation regarding the aneurysm. Samin, another question for you. Have you ever used rapid pacing for unprotected left mains?
No.
Got it?
Rapid pacing is only used where you know there is lot of cardiac motion and you want to nail the ostial circ, nail the ostial ramus, nail the ostial LAD.
And that is one way. For the rapid pacing, I say another way, simple way
Or
is give
adenosine
adenosine.
also. Adenosine
Give
also.
adenosine. So you got a total stent still for a short while, and then it's easier to deploy the stent in the right place. So now we are trying to make a this is Miracle 6.
Miracle 3.
3. Okay.
Have the 120, you think, if
yeah,
you need it?
Yeah, yeah. Get
Supercross ready?
Supercross 120.
They said, no need, don't open.
Yeah, but that's okay. Yeah, open it.
He
Fine.
said, is have it
good.
ready.
Yeah. Good.
Okay,
So
now
we
go
go
to
to
cranial.
other view. Which one?
Cranial,
Cranial.
cranial. All you needed was a
Little stiff.
acute curve with a stiff, which is, this is a Miracle 3. Wire. Okay, some dye. So now I'm in the LED. Oh.
Yeah. Ready for IVUS? We are going to do IVUS soon.
So
Get
no,
that
what I
extend
want
that
to
wire.
do is change to rotawire.
Yeah. Okay.
And we'll do IVUS on the rotawire.
You want to do IVUS on the rotawire?
100%. Okay, give me to rotawire. You want to do the rotawire, right? Give me.
Why are you taking wire?
So Samir, you saw the steps we did, right?
Absolutely, and go ahead, explain them once again for the
so
viewers.
is the view. So if I can tell you, this is the view that actually told us that how was aneurysm coming, because initially we were wiring with the views that we have. Cranial was not helping us. This view was not helping us. See that? Here it looked like, if you see here, it looked like from left main to LED is very easy.
No, but it isn't.
Yeah,
I
so
think,
when we were wiring here was not easy. So this is what I took the picture, that
eccentric
see
lesion
how,
and the sharp
how the wire
angle.
is getting lost. So then what, this was just the wire, then I changed, you need some support, so we went to fine cross. So with the fine cross, this is the picture we took, and this is how we know.
Which is
see how
what?
the LED is actually coming from the aneurysm. So you have to enter the aneurysm and then make a acute turn.
And the wire would be coiling in the aneurysm also.
Yes, yeah. That is why we selected that you need a little stiffer wire that you are able to make that acute turn.
And
you want to show what the curve we made.
Samin had observed about using the Supercross too.
Yeah, otherwise if this has not helped us, then would have been a supercross. This is the curve that crossed, if you can show it.
Samin, another question for you here. Unprotected left main and rotablator, would it not qualify for impeller?
Yeah, no, as I
we
said.
went through this.
Yeah, so basically the same which we had a little discussion earlier, that whereas that we did the the Protect trial, and we were the second lead enroller because we started 1 year later. So basically the Protect 2 trial, which led to approval of the impeller device, had the criteria was left main with an EF of 30%, 35%, or 3 vessel disease with an EF of 30%. So those were the cases, means complex coronary anatomy. So now this patient has a normal ejection fraction. So question was, then they presented the data with the US PALA registry that many of these patients do undergo hemodynamic deterioration, particularly when you use your devices. So maybe Impella is a good device for that. So what FDA approved now, Impella for patient with the normal ejection fraction but with a complex anatomy. So this patient by guideline will make it, not by the Protect 2 guideline, but will make it otherwise. So then question comes that do you need it?
Complex PCI, although
Yeah.
they have truly not defined what complex PCI. So definitely unprotected left main, rotational atherectomy, bifurcation intervention, then CTO. So even if it's normal EF, you have 3 vessel disease. You
So
see
it
this?
definitely
It's going.
justified. Yeah.
Yes, Samin,
Then
another
one
very
X-ray light
interesting
come to
question.
fix it moving. Yeah. Yep.
Cannot do now.
from Oman.
Yes.
So this is, we've had first one from Libya, second from Oman, and this question is that was a CT angio done to better evaluate this aneurysm? I think the answer is that the aneurysm has definitely increased and had not been seen 6 months ago
Yeah, exactly.
to this level.
Right. Absolutely. But question comes the same, that even if it's aneurysm, it's not going to change our practice. Right? This
But a
patient needs intervention.
Good observation that it may have been a good way to evaluate.
Okay, can you start the IVUS and start
Live.
recording?
Yes. Yeah. So while we are having a discussion, which yes, the point is what are we going to do different?
So this
These
is a mid
aneurysms are
LED
left
lesion,
alone. Yeah.
right?
Yep.
So we got to stent right from there. So bookmark there and give us a cross sectional area. Okay. Yeah, there give us a cross sectional area. And now we are coming towards the
Yeah, look at
Left
that.
main.
yeah. This is the LED. LED ostium. Can you see the aneurysm? That's aneurysm, right? And then we are coming towards
No,
the.
aneurysm has not come here.
No, that was what it was.
Yeah.
There you go.
This is
There
this
we
is
go.
it.
Yeah,
Okay.
Yeah. So it's actually at the distal part of the left
Septum.
main.
right.
Distal left main.
Yeah.
No, that you cannot say. Distal left main heavily calcified.
Yeah.
360-degree arc of calcium. Maybe that's the reason we did not get into the circ, right?
Yep.
Okay, we can stop. We have 175 bar opened.
And what balloon we have?
We have a 3.0 for the mid LED and a 3.5 for the left main.
Okay.
And a cutting balloon if we need, we have
4
standby.
of 4 of is a Wolverine. Yeah.
No, don't do that.
Hmm?
Now into the aneurysm with the 4.0 Wolverine.
Okay. Good. Let's keep it covered and let's get this.
I would not go for a Wolverine.
Okay.
89-year-old lady.
Fine.
Yeah.
So now you see that setup of the Rota Pro. So clearly it has lot of plus minus, lot of plus, and then I'll tell you the minus. Plus is everything is on the table, on the Rota console, your advanced knob. So no worry about the tachometer, your pedal, everything is there. The speed is usually fixed. The little disadvantage is, which they are changing, the cable. The cable comes with the curve. Make sure you, once it comes out, very important that you take out from the basket for the box it comes, that you straighten the cable. So because the angulated cable is the one continues to give a trouble. So you have to keep it straight, and they are changing this because it's still too close. Many times it just push the device, the whole the advancer down. So once you have undid it straight, some people actually put even a clip if necessary, but keep it straight. So the other point which we also saw, that the movement is less friction. So you have to be careful that you don't advance it too much compared to it has a less resistance. So need to be careful. Although as I mentioned that lot of plus points here, taking the whole assembly simpler, but a few points need to be while being changed. One of the issue is there are multiple buttons. So all those will change in next few months also. That one button on the top will become both Dynaglide as well as the main speed. So key is things will change, but most important this we call Python. Python will become simpler in a coming very soon, within a few months, and so because that's one of the big disadvantage which people have said about it.
Okay.
Yeah. Ready?
Let's
now
go.
we are ready to and the
Speed
rest
check
of
was done, right?
yeah,
I
yeah,
did.
yeah. And the biggest thing also, it requires very little change in the speed. It comes with the same 160,000 RPM, and I can tell you 90% of the time you don't have to dial up or down. In the past, when we are doing with a standard Rota, we used to tell the technician go to the machine. They will be, looking down, bending down, breaking their neck and back. Not needed. Now it's just straightforward.
Used to happen in virtually every case.
Yeah, exactly.
Samin, more questions coming about managing and dealing with this aneurysm. The question from Dr. Pranab is hydrophobic or hydrophilic wires if you have an aneurysm?
No, I think it has to
Hydrophobic.
phobic. Yeah.
Okay.
Hydrophilic will be lost more.
Lost and stiffer. as you saw it here, require.
Huh?
Yeah, that's
Yeah,
okay,
yeah,
yeah. That is required little stiffer tip to cross.
Oh wow.
Went easily. huh?
175 bar did nothing.
Yeah.
What was the cross sectional area of the left main?
You're just at the
The left main was 3.6, so truly narrow. Yeah.
Okay,
That's it.
good.
Yeah.
Would you contemplate a larger burr, although now
Don't give
the-
that.
you
Don't give
you
that.
have a 6 French guide, so
Yeah.
Okay, I don't think you need a larger bar.
okay.
Yeah. I would say this is the kind of case you'll couple with, and that is where the whole question came down to, that what's the wrong with Impala. I would say this patient a little younger, no issue about the dual anti-platelet therapy, not issue of the NOAC. I definitely, it's appropriate do the Impala. Now, Impala has advantages, but same thing, higher vascular complication. So that we need to be worried about. So that's the reason we did not use Impala in this particular case. Now rest of the technique is the same way as we do a packing motion back and forth slow and decrease in RPM. As I mentioned, be careful that it's a very low resistance of the advancer. So you have to just let the burr go, don't push it through, because we saw that a few months ago when we had the burr stuck because
Right.
it went a little too easy. So very important, but all these changes are going to happen soon to our advantage, making the whole assembly much simpler.
Any use here or intention to use the cutting balloon further, or
Yeah, let's see now. So you want to take a picture or you want to put a wire again?
No,
Different
we have
wire?
to go with the fine cross and change
Okay.
it. Remember, this
Get
is
the
not
fine
a case
cross.
where you can go side by side.
Go.
Go. Nice. Okay, give us the fine cross. We have the long run through. We use the same one. Yeah, and then we just.
So while
take
we are
care of-
changing the wire, let me just go through our little bit of discussion, because right now we are
No, no,
just
no,
changing
Let's
the wire.
finish
Right?
the case now.
Huh?
Let's finish the case. No more discussion.
Samin,
We're done.
going back to the issue of FFR to help and guide CABG, logistically, so how your patient comes, has a coronary angiography, so you now go ahead and FFR all 3 vessels? Or
Yeah, that's
where-
a very good point. So what has been done, actually there is a called syntax 3 revolution. Syntax 3 revolution, they are saying that in the cases where you want to decide FFR guided CABG, so you can do the CT angio and in those cases. And maybe even check the FFR with the CT angio, which has a very good sensitivity and specificity, predictive
pull
value with your invasive FFR.
That was not done in the 2 trials you
No,
mentioned
no,
about.
no, that's a separate field evolving. Patrick Sorai presented last year in
Yeah.
TCT, the syntax 3 revolution, that a CT measured FFR has a very good correlation with our invasive FFR. So that, like, coming back to the point, the patient who already have a cath, now you don't want to send the patient back for FFR again, and therefore it will be reasonable that those patients, if you are questionable, that do the CT FFR, and that data are supported in the literature by a trial called our syntax 3 revolution.
Right. It's going to be a while before we have clarity on this area. What's your gut feeling?
Oh yeah, actually, you know what? If while we just, okay, tell us what balloon you are going to use now. Yeah.
No, no. So what we will do? I think we'll go with the regular balloon.
No, high pressure you mean.
Yeah, yeah. High pressure means
Yeah.
means not
Yeah.
cutting
Same
balloon.
3O.
We just go with the NC balloon.
Yeah.
But you
And
want to
see
do
how
the left
things
main
are.
first, or you want to do the mid LED first?
Mid LED first.
Mid LED first, yeah.
Okay, then it will be 3O. You don't
Yeah.
want 3
Use
5.
3O. 3O.
Okay, get us a 3O. What
Yeah.
you have? 15?
Yeah, I can just go back to one slide, because that was the last part of our presentation and I stopped that. So that is the ongoing trial called FAME3. And FAME3 is the trial of patients with the multivessel disease, de novo, not involving the left main, and there all heart team discussion is happening, and of course acute KMI patients are excluded, so and so forth. It's a 1500 patient trial, and patients all will get the Resolute in the PCI group with the FFR guided, but CABG group is angiographic guided. FFR is done in these patients, but the surgeon will be blinded to the FFR finding, and they will do the bypass as they wish, because surgeons so far have not come into opinion agreement that FFR should be used during CABG. So, coming back to the final statement on this field, that I would say that maybe in an isolated case where you have some ambiguity of the lesion, that whether you should put out if the lesion is significant or not, maybe the rare case of the ambiguous lesion 60-70% whether band or so and so forth. So, that case in my opinion can get a FFR guided CABG. Otherwise, all should be done angiographic appearance, and I think this whole issue of the proximal lesion the protection by having a graft in the distal vessel, we cannot underestimate, and we really need to see, and you know, this is where we need to
go out. You see that did not expand.
Yeah, but you need a bigger one. It's a 20 atmosphere. Yeah.
Okay, down.
One of the other
Down,
issues
down.
is that as it was shown in the trial by Dr.
3-5-12 high pressure.
in the Fargo trial, I mean 6 months is not really the ideal period to.
Right. That is true. So, one of their biggest concern was in the trial that if you are leaving the lesions, is there a progression of the FFR, although that was not a part of the primary endpoint. It was actually like co-secondary endpoint, and 6 months graft occlusion, which occurred in about 14-15% of cases, was identical in both the group. But you are right, 6 months is way too early, and we had to have a data of minimum 3 years. So, we learned in the PCI also, actually it has to be the data of the 3 to 5 years. I think similar thing should be here, because all the trials, Syntax, Freedom, the Barry, even Barry trial, curves of the PCI versus CABG only separated after 3 years. So, 3 years is a very short time.
Anu, question for you here, which has come through. Any
you take this
preference
IVUS
of a
out?
particular stent
can
in
see.
view of the aneurysm?
Yeah, what is stent selection?
No, I mean nothing particular. I mean, of course, ideally you want to close it. You probably have to go with covered stent, but covered stent has very high restenosis, so we are definitely not going to do that.
And not only that,
Yeah.
here you will kill some
Yeah,
branches.
kill the
More
branches
important
and
is the
circ.
branches, yeah.
Where we may lose the circ also.
Yeah.
But what I am saying is, if you had in the RCA,
And
mid
we actually
RCA,
had
you
it.
can,
Yeah, we have put
covered
some
stent.
covered stent in the proximal LED, which the surgeon said they
And
cannot
you have
do
put
the
covered
yeah.
stent in the vein graft where you have seen some aneurysms.
see
Yeah,
it
but
or
not
just go
here. Yeah, yeah. See that the dye staining is in the aneurysm, right?
Let's see.
Yeah,
Okay,
yeah,
I'm doing
yeah,
little
yeah,
dye.
Yeah, yeah.
It's
See,
aneurysm
that's an
versus distal left main, both.
No, no,
yeah.
it is aneurysm.
Okay.
thing. Okay, so go up here.
That's
This is a
the
12,
3-5.
3, 5, 12.
Why didn't you go 4? Okay.
No, no, we said we are not.
Okay.
Okay.
4 if need to, we will go to the cutting balloon. So clearly, you want to magnify? Yeah. So
Still
there is a
there's a
dent
little
there.
waste
see?
there.
Yeah. So I'm going to 20 atmosphere.
Good.
Opened up.
Opened up.
Open nicely. So that is the key.
Down.
Rota, cutting the eccentric. We are going to go back again. That eccentric little cut, subsequent balloon facilitated PCI. So really have plaque modification. Ready?
Yeah, I don't think you need 4.0. We can direct stent. Question is, what
Two
should be
separate
the
stents.
stent size?
Two
Oh,
separate
so
stents.
separate
No,
stents.
2 separate stents. Mid LED separate, give it a gap, and then one separate here. Here you need a bigger one.
Why they show it too much? They can't ask us all.
Let's take a picture.
Go.
What is the size of the left main?
So, Anu, here is a question from
Okay,
Chris.
so you want a 3.012 to the mid LED, or you want
Yeah.
to come all the
3
way
or
down?
12. No, no.
You want to way down?
Question for you. Would you want to wire the circ now?
Yeah, we'll try that. Let's do the LED first. Let's finish the LED after the diagonal. You want, because of the dual antiplatelet therapy issues and all that, in this particular case, shorten the duration, like senior trial of 75 years of age. You can even stop after 1 month, which was better than bare metal. So I would say we go for synergy in this particular case. So let's get our 3024 synergy. Right?
Where to where you are going?
From just at the level of the diagonal and to the segment.
All the way
Yeah,
down?
Yeah.
Synergy is not good for left main to close. It's very thin stent.
Yeah. Only question will be that for the
It's
left
thin.
main, do you want a little thicker strut then the thinner strut of a synergy. Isn't the synergy 4O has the similar stent strut thickness as of the 4O?
Promos.
Yeah. Or the 4O is will be the same. Yeah. And the 4O what? 18 or 16 or 12?
No, how? 12.
4O 12.
Short,
And
short.
then 4O 12 with the 5O balloon.
No. They're
You'll
getting
see
crazy
later.
here.
Yeah.
Please.
You'll see it.
Ayo.
Okay. So now, as I said that we are right now dealing with the mid LED.
So you see that diag, just after the diag we'll place the stent.
Go. One of you can remove the rota. We don't need rota. IVUS will need.
At the end.
Yeah.
Okay. Some back.
Oh, sorry. 20. Just will die.
Yeah.
Good.
Nice. Okay. Go. See, even that caused a little dissection, right?
Yeah.
This is a 3-5.
3O.
3O
3O 24. Synergy.
for 16 atmosphere. Keep fluoro. Right now, then become black. Yeah.
Okay, good.
Yeah. Let's get which wire you want for the circ.
I think the run through went. Give me the short run through we had. Okay, you want to take a picture? Quick picture, document. That we are good.
Low mag.
Yeah,
Good.
nice.
Beautiful.
Okay, and we will wire the circ
Yeah.
and a 4
Now
or
try
12.
to see the balloon now. So whether our wiring the circ, can we advance any balloon? Your earlier 3O balloon which you had, maybe we can try. Go to the caudal view.
Same view, not caudal,
Yeah,
which was like a crazy 58 LAO and 19 caudal.
And your 3O balloon separate, right? Okay, bring the screen down.
Samin, another question has come in.
Yes.
If this case was being done with wrist access, should one put in a sheath for possible hemodynamic support?
Yeah,
What?
I guess so. No, they're saying if we are done radial, would you have a
No,
femoral access ready?
no. I mean,
For,
the whole purpose was that if you feel that hemodynamics should be done. So I always say that any data, any time you have the bailout has a less impact in terms of overall outcome compared to you do electively. That we learned for the balloon pump, we learned for the impeller device, and so all these cases. Once you decide, you should do. Now, rare case, when acute complication occur, what you do at that time. So I would say that if patient had a low ejection fraction and for some reason you didn't want to put an impeller, which should have been a clear indication, that still will die. Yeah. Good. Yeah,
Samin,
then that case I would have put a small sheath in the femoral artery if you're going through the radial, or we are going through the femoral to other side, contralateral side through a balloon. And see.
What
there
are
are
we doing?
so
We're not
Just to
many
see. We didn't go earlier, just yes.
so many questions today which talked about the hemodynamic support. I just have a feeling that we continue to, whenever we have cases like this, discuss the situation, because there looks to be too much concern, too much uncertainty about the need for hemodynamic support.
Yeah, because
for
remember,
unprotected
even
left
Excel,
main.
even in the Excel trial, hemodynamic support are all done in the single digits,
Right.
and with still a very excellent outcome. Now
Okay.
see
I think it was
earlier
all
IVUS
left
could
main.
not go, and now your balloon. You want to do a little balloon dilatation? or no?
Absolutely. I knew that you were going to say it.
Okay.
That's the reason I asked.
In our own
No,
situation, I can tell you that we've been showing unprotected left main now for about 7 or 8 years.
Yes.
To IVUS?
Yep.
At least I think 25% of our cases, where a lot of them, the similar case 5 years ago, it was always done with a balloon pump or sometimes with impeller.
Yeah, that's right. So but the ejection fraction for us, is the combination of lesion complexity and the balloon pump.
We are doing IVUS again of the
It-
circ
Yeah,
now.
now
since-
we are trying to do IVUS of the circumflex, and just want to let everybody know that while we are thinking about talking about the left main as a standard now, of course, because I would say that Park from Korea has a lot to do, bring it to the main stage and subsequent trials and so on and so forth. 1998, and Samir, you remember, in our first CCC symposium, we did 3 unprotected left main. One case was the aortic dissection, which we did from the right brachial. We didn't have radial that time, so the brachial approach.
Cut down.
Yeah. So we did 3 in 1998. We did 3 live cases of unprotected left main. Oh, good. All right, let's start.
Okay, what do you predict?
It
Lesion
should
or
be
no lesion?
Mild disease.
No, okay, okay. Oh, wait, not yet, don't record. We are going to flush, let's see. Okay, start pulling back now. No disease, now we are coming to the ostium soon.
No,
This is
far away.
proximal,
Yeah.
proximal.
Okay.
Okay, this is ostium. Okay, this is aneurysm.
So not
No disease.
minimal to nothing. Yeah.
Okay, that is what we
So
discussed.
that
So
provides
now
the
aneurysm
rationale
we have
for-
identified it is in the left main,
Yeah.
at that angle of the LED and left main.
Where ramus should be coming, instead of the ramus, we have an aneurysm.
Yeah.
That's what it is. Yeah.
So that provides
Good.
a complete
Okay,
rationale
stop,
for a
stop, guys.
crossover single stent.
Yeah. Okay. So give us the distal left main, ostial circ. Show us exactly ostial circ and give us a cross-sectional area. Cross-sectional area including the aneurysm.
Okay, which we will put a stent now. The left main. Is this okay? Keep it one side. Let's get to the wire.
Yeah, yeah.
9.23. Okay.
Okay. What view you want to go now?
Cross stent now.
We have to go into the LED, right? Let's go to the same view. You don't like that view?
No, I'll tell you what with the
Okay, the
view.
epicaudal then. Yeah.
To me, this will be the view. Here. Okay, we are taking the picture, and our X-ray guys are there or they're on break? They're supposed to come and fix the machine, right?
No, not now. Later on. Stop it.
Did they know about it or no?
Yes, but not now. We cannot come. They cannot come inside at this
It's
time.
Yeah.
good
Okay,
view
now you
to-
see it now. Very clear display. We have the wire into the circumflex. There is a large aneurysm from the distal left main into the LED. Yeah. So now my question is, let's think about, no, before we go in, there is a little disruption of the proximal LED. I think we need a longer stent. You make it a 4020.
No.
Yeah. Why?
See, you have to give a gap. Otherwise, you will be double layering the diag and you'll close the diag. Okay, that's a big diag there.
Okay, then just do this. If need to,
16.
we will decide. Yeah. If there gap, then leave it. We'll deal with it later.
Let's
Yeah.
see.
Go.
12 will cover it.
Yeah.
Otherwise, have a 16 ready, 4 or 16 ready.
Yeah, possibly 16. No,
Yeah.
no.
And we are going to show that this aneurysm is going to almost disappear after stenting.
I'm not that confident
Go.
using synergy that
Yeah, I
the
think it
aneurysm
will
will disappear.
decrease, but let's see if it decreases substantially. Samin, you want to? Okay, let's go.
Did we dilate that LED?
No, we didn't dilate
Not
it.
at
Yeah.
the,
Problem.
not at that
See?
origin.
I think we just focused on the left hand. But with that was a 12 balloon, no?
Yeah.
Okay, show some dye so
What
that give
4
us
balloon
an
we
idea.
have? Get the 4 balloon.
oh, wait.
That balloon again. Yeah, it went in. Yeah.
Oh, you want to take a wait,
Yeah,
wait.
3.5.
Okay, picture.
Yeah. Make sure it's fully covered. Yeah. Proximally. Proximally we have to cover. If need to
Okay,
put
okay,
one
okay,
extra
16.
stent, will be okay in the mid. Good.
Covers
Very good.
Very nicely. I
Ready?
think.
Wait.
Yeah.
Not ready. I want to go in a little bit.
No, why? Okay.
It's too much in the
Okay.
left
Yeah,
main.
1 millimeter
That way
fine.
we are
2
all
millimeter
covered.
good. Yeah,
Yeah.
2 millimeter okay.
Okay, now dye. Yeah, good. Go.
Ready?
Yes.
Okay, this is a 4-0-12 synergy. Synergy going to do the magic.
Okay.
Anti-aneurysmal or aneurysmal obliteration stent.
Who votes that it will go and who votes that will not?
I can tell you, aneurysm will become less than 50%.
Okay.
Less than 50%.
Well,
Okay, one
Okay, down.
and get a 5 or 8 millimeter. To a, just
Do we
there,
have a
at
4,
the
5?
level. No, 5
No,
or
don't
5
get
or 5
crazy. Yes, yes.
8. No, inside at the level of the aneurysm.
4, 5.
Okay, 4.5.
What is the, what was the left main
13.
diameter?
13 millimeter.
See?
No, but
What is-
aneurysm area at the
No, no,
level
no.
of the aneurysm.
Okay.
Okay. See
Okay.
it to believe it. Let's go for it.
Still there. Okay. Went
Let's
down
see.
by 25%.
Yeah.
No, this is almost half.
25%.
What do you think,
no, I would
Samir?
not.
I think
4, 5, 4, 5.
I mean, it's
Absolutely will
reduced,
not
which
go
is
for
what the
5.
aim was.
Yeah.
What about the area in between the two stents?
Yeah,
you
we'll
think?
take care of that also now.
No, no, that I think you can leave it alone.
Yeah.
You want to put
Little
another
massage.
stand there? Yeah,
Little
like
massage.
This
We'll
balloon.
go to other view. That's a separate issue. You don't want to go to 5 for
No,
that?
I think
I would not.
4,
another
5. All right, 4, 5.
8 millimeter
Don't
stent.
get crazy
358.
Yeah, it's a 4.58 NC emerge. Hold the wire. Okay.
Media, how much is it at the distal ostial LAD? Diameter. Diameter. Yeah, so we know.
Yeah. Now we need to take that wire out now. Take the wire out.
Oh,
before-
yeah, yeah.
Yeah,
Okay.
always before you go to high pressure of the side branch wire should be removed. If you want, you can rewire it through the stent studs. But otherwise, before very high pressure, you always should practice of
Okay.
removal. Ready?
Yeah. Now we are just at the level of the distal left main and aneurysm.
Aneurysm, yeah.
Yes, good.
Yeah, this-
16. You want to go more higher?
No, down.
Little
me
massage
four.
distally.
No, not with this balloon. Down. I'm not a believer of massage. Okay, now here, ostium.
Yep.
So we know we are nicely. Wait. We are there. Okay, go up here.
Now I was supposed to get stent
Enough,
boost in
enough,
this.
Enough.
Yeah.
Yeah, good. Down.
Can we get X-ray guys, or we have to bribe them?
Okay, down.
They're
I
supposed
mean,
to stent
the,
boost.
The new
In this
year
room, what
has
happened?
also started for you with the new room.
Yeah, the new room actually will be ready next week. What happened with the, it's a very too fancy. So it is not ready for the live relay.
No, room is ready. We opened the
No,
room
live
last
relay.
month.
No,
yeah,
we're saying
yeah.
live relay is not
relay
ready.
not ready.
Yeah, it's too fancy.
Beautiful.
Go to
Yeah.
epicranial for that mid segment.
Okay.
I mean intervening segment.
Go. Epicranial, let's take a picture.
So just I think this is the answer to one of our viewer who asked the question
Yes,
that
that
do a CAT scan and so that
Dr.
yes, if
Altir
there
from
was
Libya.
there was some question about that patient is going to go for surgery, where it is happening and so forth. This is just a atherosclerosis aneurysm. Most common cause of the focal or secular aneurysm is atherosclerosis. Patient has a significant lesion, and these patients do very well with the intervention, and you are able to close actually part of the intervention. So therefore, why to risk additionally for another procedure, dye and so forth. So that was the reason that we did. Now, if this patient aneurysm is like 2 centimeter, and now we want to measure, because there are rare cases of coronary aneurysmal rupture, and that usually is like when you get to about 25 millimeter and so. So those cases, since you need to follow them non-invasively by CAT scan, that will be reasonable. That in those particular cases, you do the CAT scan and measure it. Here we have an old angiogram. It has become a little bigger than last time, but that's okay, because we know our intervention is not going to change the strategy based on that aneurysm. Now, what do you want to do? It looks very good. You want
I
to do
would-
IVUS?
We'll IVUS, but
Yeah.
we are not doing any more massage or stent,
Okay.
balloon.
For
no,
the mid portion.
Yeah, aneurysm is 25 millimeter.
length, not diameter. Yeah.
Cross section. So it's a good size. Yeah, here.
How can they
Do
use
the IVUS.
cross section? talking.
Okay, let's see what we are going to see on the
So we are
aneurysm.
going from left main to LAD. Okay,
Yeah.
guys, repeat IVUS.
This
No, that guy doesn't know anything. Please don't waste your energy.
Did we tell him the table moves also? Did we tell them earlier? You know the table moves?
Yeah, I understand he can't do anything. You think he knows anything? When have you learned this? These people don't know anything.
Yeah. Yeah, we did. So many times. Yeah, go.
Why are we on IVUS?
We are on, right? Yeah.
All right, let's IVUS and Samin, then you need to cover your second topic too,
Yeah.
which is increasingly important, keeps coming back to haunt interventional cardiologists.
Okay,
Yeah.
start. This is a mid LAD stand.
Looks,
Good.
Nicely opposed.
Yes.
Good.
think it could be expanded a little further?
No,
Looks very good right
You're
now.
okay, all right.
I know we are so used to OCT.
Yeah, no,
Yeah.
let's see the area in between now.
Yeah.
Area in between. Now the stent
Fluoro.
edges come back. Nice, good. This is
Yeah,
in
nice
between.
tumor.
Looks good.
Little-
No dissection.
A little bit.
No, no, no.
I thought there was a little intimal flap
Yeah,
at
yeah,
the
yeah,
very
yeah, that was-
That is part of PTCA.
We'll remove it,
Healthy.
yeah.
Okay.
This is
And
left main.
Left
well
main looks
opposed.
excellent. No problem with the left main.
Good.
So you are intending to leave that alone, and we are
Everything to be left alone.
Yeah.
okay.
Huh? Yeah, looks good.
All right.
Angiographically looks good.
You want to
confirmed with
finish one or
IVUS.
two pages, whatever, I mean, pictures, and then so let's quickly come back to our angiograph, the slide set
And
for
then
the
we'll go
PowerPoint
back and see the
presentation.
last
Yeah.
last image.
So basically FAME 3, as I mentioned, so that where the CABG, so right now FFR data with the CABG are very, very small, and I would say lot need to be done, like 20 years of work which we have done for, actually not 20 years, from 2007. So 12 years of work which has been done in the PCI and FFR, long way to go for the CABG. The second point is, what are the temporal trends of OC categories in PCI? Now remember, back in 2010, then we have updated 2012 OC criteria, which based on took into equation of the patient's presentation, whether asymptomatic, symptomatic, class 1, class 3 or 4, and also the patient's medical therapy is anti-ischemic therapy, then presence of how bad the ischemia was, and lastly the presence of coronary artery disease, whether one vessel, two vessel, proximal LAD, multi-vessel, and so. So that really gave us a good idea, with the red being inappropriate. So we didn't want to do PCI inappropriate. Lot of data showed that almost 18-20% of the PCI in America were inappropriate by those OC criteria. So with that note, so clearly that the whole country got into the bandwagon, really that try to not to do inappropriate PCI. So there are many papers which came out subsequently. This is from North Carolina, that clearly that you can see inappropriate from 25% went down to 13%. So the country, so if you say that what is the tool which we use in interventional cardiology, change the practice, change the habit, change the from quality point of view, I would say OC criteria really made a major impact, bigger than even the CABG trial. So OC actually declined the PCI number by 17%, while CABG, when the CABG trial came in 2007, PCI went down by 12% in the country. And
So, I mean, just to, sorry to interrupt you here, somebody with a little doubting mind would say that only 53.6% are appropriate.
Well, no, appropriate, yeah, but remember, appropriate and uncertain are in the same category. So appropriate is class 1, uncertain is class 2A or 2B. So if you take both of them together, that will be 85% or 86%, which is okay. And what we have been teaching everyone, that your inappropriate number should be in single digits. And Sinai, traditionally, we started back in 2012 when nobody knew about this aspect. You remember, we made our slides right in 2011. This came out by Manish Patel in December of 2010. 2011, I incorporated in our slide, first slide of 2011. People can go back to the webcast, that appropriate criteria I incorporated in our case presentation. Since then, every case we have shown that, and our inappropriate number always has been around 5% or lower. So now they also showed that the groups which are higher inappropriate really did the best job. So very high inappropriate, let's say highest group 3, which is the highest tertile, became 9.4%. So just to say that it affected everywhere's practice to change the trend. Now, what about the patient presenting with acute coronary syndrome? So what also happened during that, I think more so impact of the Courage trial, that patients with a stable CAD being managed on medical therapy, and only when they the refractory breakthrough, they come to the cath lab. But clearly the proportion of patient now over the years since the AUK introduction presenting as acute coronary syndrome has increased from 69% to 82%. Now then the second data, so basically it shows that the overall AUK criteria made a change in the practice. Then we have the data from New York State, which I am one of the author, change in PCI of the inappropriate, and the basically showed the same trend, but one another very important one. As you can see, the 2010 other, Medicaid and total. So see the Medicaid significant decline compared to any other category of the inappropriate. Why? Because 2011 New York State sent the circular that inappropriate PCI will not be reimbursed, and that led to a much more decline of the inappropriate PCI in the Medicaid group compared to other. So Medicaid primary, you can see significant reduction, almost half, compared to 18.6 went down to 10.6, but Medicaid group went down from 16% to 6.8, more than 60% reduction, because not being paid if you are inappropriate by the New York State criteria. So these are the individual same pattern, but the early that the inappropriate number went down by even based on the tertile when in each time period when patients were there. So this was really led to, so now we felt that we had done very good for appropriate. Now the latest letter comes in JAMA that raises concern about overuse of stent. Now what was this? This study is done temporal trends in unstable angina diagnosis code for outpatient PCI. So this basically originated by the state, the data collection by 3 Florida, and Michigan and the New York, and published by our Women and Brigham Hospital, Harvard group. These are the very well I would say respected authors, and basically showed very alarming. And very alarming is this. Look at the left side of the screen. So patients, these are the three states, Florida, Michigan and New York. So outpatient PCI, acute, they define as patient having unstable angina or MI. So acute diagnosis of the outpatient, you can see for 0.6% in the New York went to 8.3%. So clearly like 15-fold higher diagnosis in last 5 years. So you say, well, maybe that is true. Maybe that is because more acute patients are getting PCI rather than stable patients are coming. But this is what something really we need to think about. Second group is the patient in the Michigan as well as Florida. Everyone had a trend from acute diagnosis of acute coronary syndrome, because acute makes it appropriate from the AUK criteria. Now, if you take acute diagnosis for the inpatient, you see it's kind of a flat, particularly the New York. No change. There was slight increase in the inpatient acute diagnosis for PCI, but definitely not as what you see in the outpatient setting. So now, then in the three states, they actually have same whether unstable angina or acute myocardial infarction. So whole issue was, what is this acute all about? Is it MI or it is the unstable angina? It turns out to be across the board. It is not the MI. It is the unstable angina. So what is saying is that non-STEMI or MI is not increasing in America. What is increasing is unstable angina or diagnosis of unstable angina. patients coming to the chest pain unit, patient coming to the emergency room, patient coming to the places, the unstable angina. So the author basically kind of summarized that maybe it is the gaming of the unstable angina to make it an appropriate PCI. So therefore, what we have inappropriate PCI number going down, maybe just because the coding is different, the practice is different, but I would strongly argue against it, because clearly we all have become very careful identifying patients which are inappropriate. Everywhere in the country, fellows, attendings all are taught not to do PCI if it is inappropriate. Here also at Sinai, we have our 8-9 fellows, and any patients who will be in the inappropriate category will come to the attending and say, you know, this patient does not make sense. Some cases you still have to do it because of symptom, patient has a VTAC or some other region, but key is the inappropriate practice is going on, and that has really, I would say, changed the pattern of PCI. So then, of course, having all this, our friend, the gaming, upcoding, fraud, and the stubborn, persistent, or unstable angina, the letter to the editor by Dr. McKeely and David Brown from Washington. So said the same, that it's basically that bad thing is being done in interventional cardiology. And I can tell you, I absolutely disagree that yes, the patient's shift has happened from stable angina to more acute syndrome getting PCI. But it's not that is any gaming issue going on. Yes, there is a less non-STEMI. Clearly, why? Because of the statin, because of primary prevention. So MI numbers are low. It is the unstable angina which are bringing to the patient, and we are not, the stable angina is not what is causing increase in our PCI numbers. So it's actually the PCI numbers are flat or decline, and more appropriate are being done at this time. So just to quickly summarize, non-randomized data supported benefit of FFR during CABG, but first randomized trial incorporating FFR in the decision making for bypass grafting showed no difference in 6-month MACE or graft closure, but progression of the deferred lesion to significant FFR of less than 0.8 in 1/3. Fargo trial. Hence, until randomized clinical trial establishes the utility of FFR in CABG, FFR use should only be reserved for ambiguous lesion to the graft or not to graft that vessel, and those cases should get the question is, if there is ambiguity, should you get arterial bypass or venous bypass? I think those cases should get the venous bypass, because we know arterial graft patency is much dependent on the native blood flow, comparative flow. Very, very important statement. Second, the adoption of OC criteria in routine clinical practice has resulted in significant reduction in inappropriate PCI being done in the United States. We need to strictly vigilant the patients, that patients with unstable angina are appropriately coded to continue fair and appropriate practice of PCI, and I think we had done a great job of changing the face. A lot of publications a few years ago, even in the New York Times and follow up in the Wall Street, that PCI, really more appropriate PCI being done in the United States, more complex cases are being done, but this gaming and this bad word should not come to the interventional cardiology. So very quickly, 3 questions. Following statements are true regarding FFR guided CABG, except in the observational studies, FFR guided CABG was beneficial. FFR use results in lower number of grafts per patient. Fargo is the first randomized clinical trial comparing FFR with the angio in CABG. FFR is unchanged in the deferred lesions, and FFR use is not associated with higher graft failure. So basically, what is true? True is everything is true except B. FFR is unchanged in the deferred lesion. We'll be answering the questions after we present, since that has been our focus. I mean, that's what we do for structural heart. Anu suggested that we should be answering there now. But just to tell our viewers that in the old questions which we have, once you go to the end of the presentation, you will have an answer to all the questions in the end. So we present the question, but we never gave the answer in the past in the CCC live. Coronary cases, although structural we do, but answers are always there in every case there. Second, following are the possible explanation for improved outcome after FFR guided CABG versus angio guided CABG, except FFR guided CABG has shorter pump time. There is a higher graft occlusion in functionally non-significant lesions. FFR guided CABG results in higher anatomically incomplete revascularization. FFR guided CABG has similar arterial or venous graft types, and FFR guided CABG has higher graft occlusion. we could know every study have shown rather lower or similar graft occlusion with the FFR. So, incorrect answer is E. Third question, following is not the temporal trend in OC pattern for PCI. There is a significant reduction in inappropriate PCI in USA. There is a higher proportion of PCIs done for ACS versus stable CAD. Recent report from a stable state database showed no trend change in the outpatient PCI labeled as acute. Recent report from the state database showed minimal change in inpatient PCI labeled as acute. And lastly, there is suggestion that overall decline in inappropriate PCI may in part be related to shift in diagnostic or coding practices. We clearly know the big issue has been, which has been raised by the JAMA authors from Harvard system, is that there is a more diagnosis of acute outpatient PCI. So, answer C is correct. With that note, we finished our presentation for today.
Samin, quick one or two follow-ups. First of all, my own individual take on this coding thing is that this is not the end of the matter. We'll hear more about it and of course, we'll address it. Anu, there was a question for you regarding in this patient as well as even otherwise the indication and the use of POT.
POT?
Yeah.
We actually did POT, means in the sense if you can see POT, let me explain, is a proximal optimization technique. Essentially what it's when you do it is when you are stenting between, there is a discrepancy proximal diameter versus distal vessel diameter. Like you see here, LAD was about 3.3 I would say, and then left main just above 4.0, and I was actually confirmed it was above 4.0. So, what we did, you take 4.0 stent and you deploy at 10 to 12 atmospheres across left main to LAD, and then what you will do a shot, we took a 8 millimeter 4.5 and you go high pressure of the proximal part of the stent which is the left main. So, you know it is well opposed, and that was confirmed by IVUS. So, POT was done here, and also what we did POT was to make sure that stent is well expanded at the level of the aneurysm, hoping that aneurysm will gradually collapse.
Anu, excellent case to start the new year. I thought our webcast today was notable for the numerous questions which were asked, as well as new viewers from Libya. I want to thank all of you for making it interactive, and we'll see you February 19th for session 116.